Welcome to Preparing for the CDCES Exam 2025. This is our Step 2 program. We have a Step 1 webinar, which describes all the different things you have to do to get ready to apply to take the CDCES exam. This webinar is dedicated to those who are preparing to take the exam in the next 6 months to within the year. And so if you're taking the exam, within the year, you're in the right place. And if you need more information about all the qualifications to participate in the exam, that is our Step 1, which we provide again later this year. I'm Beverly Thomassian. I've taken the CDCES exam 7 times, and I've passed every time, so you're in good hands. I take it every 5 years to renew my CDCES, just so I know it's on the exam, and I can give you all insight, information, as far as strategies and, different areas that are more emphasized at different points of taking this exam. And I'll be sharing with you, of course, test taking strategies. My pronouns are she, her, and hers. Let's kick it off with a land acknowledgement. We acknowledge and are mindful that Diabetes Education Services stands on lands that were originally occupied by the first people of this area, the Mechoopda. We recognize their distinctive spiritual relationship with this land, the flora, the fauna, and the waters that run through this area. This is our website. If you haven't had a chance to check it out yet, we have so many free resources. I'm thrilled about sharing these with you. On the top left, on the right-hand side, more to the left, we have a CDCES Coach app where you can launch the app and download it on Android and Apple devices. And this app is like having a coach in your pocket because it has our pocket cards. And if you don't have our pocket card yet, here's our glucagon pocket card. And here is our insulin pocket card, which has insulin and injectables. So you can order those to have your own physical copy, or you can have the latest version in the app at any time. Also, you can download it on our website. Right here, it says download free medication pocket cards. I encourage you to subscribe to our newsletter that comes out once a month. And if we have any sales, we'll let you know ahead of time. And so on this, if you press this free button, there's a lot of other resources, including webinars, cheat sheets, and other information that's really relevant to your clinical practice. The secret sauce of my company is our team. I have an amazing team. We have Brianna, who's our director of operations, and we have Tiffany on the front lines answering your emails, your phone calls, your questions. She's our customer happiness expert. You can, reach out to us and we can help you not only on your pathway to certification, but to help navigate our website and online courses. Our company, Diabetes Education Services, is dedicated to inclusion. We are committed to promoting diversity and inclusion in our educational offerings, recognizing, respecting ability, age, culture, ethnicity, gender identity, sexual orientation, size, and socioeconomic characteristics. Throughout our courses, we weave social determinants of health, recognizing that people come from different lived experiences, and we want to make sure and address those as part of our content. What are we going to talk about today? Well, this is our Step 2, so we're assuming you're ready to take the exam. We'll talk about exam content, study strategies, test taking tips, and resources. And as I've mentioned, you can refer to our Step 1, Becoming a CDCES webinar for information on qualifications. That we're going to be broadcasting June 17th. And this Step 2, Getting Ready for the Exam, we broadcast about every 2 months, I would say. Our next one is May 28th, and if anyone here is interested in pursuing their BC-ADM, we have webinars on August 7th and November 20th. And I just thought I'd share some fun facts or fast facts about CDCESs, and 43% of those who are certified as diabetes care and education specialists, 43% are nurses, 45% dietitian, 9% pharmacists. So we have pretty great representation here. 3% all other discipline. 20% of folks are age 30 or less. 21% 31 to 35, and the 16% age 36 to 40. So there's 19,000 folks or healthcare professionals certified in the United States, and you can see the demographics and ethnicity breakdown here. And I think when we look at this diagram, we definitely have some work to do in promoting inclusivity and diversity in our profession. And that's one of our big goals. We are calling out to all healthcare professionals to say, if you know somebody who's interested in diabetes, but is working in a different field as a healthcare professional, invite them over, invite them to join our webinars, tell them about this profession, share with them how fantastic it is, because we certainly are seeing an increase in diabetes and prediabetes. Currently, over 50% of people in America are living with prediabetes or diabetes. So that means about 16% have diabetes, another 38% have prediabetes. We need all hands on deck. And so I love the definition of what a CDCES, how do we define ourselves? Compassionate teacher and expert who, as an integral member of the care team, provides collaborative, comprehensive, and person-centered care and education for people with diabetes. So we are committed, our company, to providing scholarships and supporting mentors. So if you are a mentor and you're helping other people achieve their CDCES, please reach out to us. We have resources and tools that we can help you and give you discounts on courses for a group of individuals. We really want to make a difference, and our goal over the next 10 years is to mentor over 500 new diabetes care and education specialists. So let's build bridges together. I want to let you know that our company, Diabetes Ed Services, has no relationship with the certification board who administers this exam. I have no insider information. I get the information I share with you in two ways. Number one, I go to the website, cbdc.org, and I see what's the latest they're posting. And the other way I get the information is from my own testing experience. So that's how I'm sharing it with you. And we definitely, make sure to keep those channels of communication separate so there's no conflict of interest. If you go to the CBDCE handbook checklist and you can say yes to all of these different components of qualifications for the exam, then you are ready to sit for your CDCES exam. I won't spend time going over it, but just wanted to flash that on the screen. When you apply to take your CDCES, you're going to receive an instant notification. It's either going to say, yes, you're approved to take the exam, either apply to take it at a testing center or at a remote location, or you might have been selected for an audit. A certain amount of people, maybe 5%, are selected for an audit. It's nothing you've done wrong. It's totally random. And if they do ask you for information, they're going to ask you to send in licensure, documentation of professional practice experience, and that means a journal of your weekly hours providing DSME. As long as your supervisor attests to it, it's considered valid and they will approve it. So once you have that supervisor's signature, they're not going to do any further investigation. It's considered, accurate. And we do have an Excel document where you can document your hours, so that would be and track them. You need to have CE course verification and employment verification. So have these documents ready when you apply, just in case they ask you to submit them as part of the audit. Now, the exam is actually administered on an ongoing basis, and once you're approved, you get 90 days to take the exam. So once you go into the computer, submit your application, and they say, yes, you need to choose where you're going to take this exam within 90 days. And if you schedule an appointment at a testing center, make sure to do it early so you get your choice of testing centers and the time that you most desire. You can also do live remote proctoring. Now, live remote proctoring has improved over time. When I did it, like the last time I did it 3 years ago, it was a little clunky, I must say, because you need to download software onto your computer. You need to make sure it's working correctly. And then you're going to have to log on hour early to make sure all the technology is working for your exam. So that means that you're going to spend a little more time in front of that computer if you're doing live remote proctoring. And the thing about it is, you are not allowed any breaks during your exam session. So it's not only the 4 hours of the exam, it's that hour of setting up beforehand. Like once you set it up, you can't leave and say, oh, I'm going to use the restroom and come back. No, you need to be in front of that camera the whole time. So just consider that. I like to move around a lot. And during that exam, I just had to sit like, completely still. Because I don't, if anybody walks in to your space or a dog barks or, you look away or you're not in screen, you could get disqualified. And so that's just something to know about this exam style, the live remote proctoring, to see if it's right for you. When you're done with taking this exam, whether it's at a testing site or remotely, you'll get a pop-up screen at the end saying, yes, you have passed. And then they'll send you an email with more details about your score. So you will get the results on the same day. Now you can retake the exam as many times as you would like. And the first time you take the exam, it's $350. And once you pass and you renew, and you have to renew every 5 years, it's $250. You don't need to take the exam every 5 years like I do. You can renew with CEs. And I would say 99% of people, 99.5% of people renew with CEs, but there are some others out there besides me who renew by taking the exam. So that's kind of an interesting stat. Now, how do they score the exam? Well, you're going to get two scores, a raw and a scaled score. Now, the raw score is just how many answers you got right. And the scaled score is derived from the raw score. And what all this means is that to make sure everybody has the same difficulty of exam, they're going to, like, some questions might be super easy, like I'm worth 1 point, and other questions may be more challenging, that they would be worth 3 points. So they want to make sure that everybody has the same degree of difficulty on their exams, because no two exams are, alike. And so you're going to focus on your scaled score, looking for 70 scaled score units to pass. Now, what is the passing rate for this exam? Well, it's around 70%, and it's remained pretty consistent. It took a little bit of a dive in 2012 when they went from paper. I think it says they went from paper to computer, and then 2015 the test was updated and they made some adjustments. So pretty consistently, 2/3 of people pass. What does that say to you? It says you're likely to succeed at this exam. That's great news. But it also says we really need to focus our study efforts on material and content that's going to be beneficial, because it's a hard exam. It's not a 90% pass, it's 70%. And so you want to just be very ready for this exam. And I'm going to share with you some strategies to be very ready. On the exam, the questions are linked directly to a task or tasks. And so what they're trying to do is simulate you with that individual living with prediabetes or diabetes and getting in your head. It's like, how would you sort through this information? How do you get to the best answer? How would you approach this? So it's a challenging exam to write, because they're trying to set you up in different situations and see what your critical thinking is. And it's designed to test if you possess the knowledge necessary to perform the task or have the ability to apply it to a job setting or situation. And so what they're trying to say is, yeah, you might know what metformin does, but can you sit across from a person who maybe has some kidney disease or other, maybe they drink, more than 6 beers a day? Is that person a good candidate for metformin? They want to hear your critical thinking and make sure you can get rid of false answers. So getting rid of false answers is a big part of this exam. They want to make sure you know what things are wrong. And then, of course, what bubbles up is the best answer. 25 of the 175 questions are new, but they're not counted in the determination. What does that mean? That means they're just testing out new questions. They take a long time making sure that the question is really assessing people's knowledge and that the question is written well. So they'll rewrite a question if a lot of people are, not achieving a successful score on that question, just to make sure it's clear. The score, then your total score is based on 150 questions. So what are they going to ask you about? Well, here's the general categories. Assessment is 37 questions: physical, psychosocial, self-management behaviors, and learning. And in the exam booklet, they give an outline of what's on the exam. This is terrific. So what you could do is just look through that booklet and look at all these different areas and say, how well do I know this content? 1, being not very well. 5, I'm a total pro. I could do this in my sleep. So what about diabetes relevant health history, specific physical assessment, biometrics, site inspection, social determinants of health? Okay. SDOH comes up a lot in this exam. Here's two things that you want to be like completely familiar with. If I woke you up from a dead sleep and I said, CDCES, pop quiz, here we go. You would know about social determinants of health. You would know about person-centered care. You would know about starting with where the person is at. You would know about ADA standards of care. Yeah. So those are the things you just want to have incorporated into your mindset walking into that exam. This is not a medical exam, it's a coaching exam. So you have your coaching hat on, you got your whistle, you're ready to support people in those behavior changes, and you're, of course, knowledgeable about nutrition therapy, pharmacologic therapy, and lifestyle activity and all of that. Let's keep going. Self-management behaviors and knowledge. I mean, that's just the crux of what we do. And then learning, assessing the learner and needs, and using motivational interviewing. So here's where really the rubber hits the road. 105 questions. This is the main crux of the test. Disease process and approach to treatment, individualizes education plan. Look at this, 58 questions. Person-centered education. I think I've said this term a few times already. On self-care behaviors, 58 in an evaluation. So again, what are they talking about? Person-centered education on self-care behaviors. Nutrition. We need to be familiar with medical nutrition therapy. I'm not a dietitian, I'm a nurse, but I better know about nutrition therapy for people living with diabetes. I need to know about exercise. I'm not a pharmacist, but I better know about pharmacology. So, and then I work in Indian Health Services at a clinic, and I see people of all ages there actually, but I don't really serve that many people during pregnancy. But I still need to know and be familiar with diabetes care, treatment, goals, screening from birth to death and during pregnancy. And I need to be familiar with my colleagues' content. Not that I'm going to, take on medical nutrition therapy, but no, I need to provide information that's accurate and instructive and helpful to individuals until they can see the registered dietitian. I need to be familiar about pharmacologic management and knowing that the pharmacist, is the ultimate expert and pharmacologic intervention. And of course, I'm collaborating with the provider and other healthcare professionals. So that's why I think this test is so challenging, because it covers from birth to death during pregnancy and all these different areas that we may not be as familiar with. Plus, it's not just looking at outpatient clinic management, it's looking at inpatient too. So we need to know about chronic conditions and acute emergencies. Okay, where else am I? Okay, I'm still on like all the stuff we have to know. Chronic complications, acute complications, we talked about this. Problem solving, living with diabetes, evaluation, documentation, follow-up. And then the third area is standards and practices. This used to be a lot bigger, like more questions was assigned to this. They trimmed it down, and they trim it down based on what we're doing and where they need to emphasize the exam. So there's more emphasis on social determinants of health, on technology, on psychosocial and diabetes distress, and a little bit less on this information here. But certainly, look what comes up again in the standard: inclusion, diversity, equity, advocacy, prevention programs, national standards for diabetes self-management, education, and support. So this outline, super helpful. And I want to tell you something. I went through this outline and made sure that our courses cover this content, and they do. I went through every single line on this, and with our CDCES boot camp, we made sure to address all of these topics. Okay, here's the other thing. If you go to that free drop down on our menu, it says, and go to CDCES prep, you'll get to this page, and at the bottom of the page, it says articles to read to prepare for our CDCES exam. And here's the QR code. And I just put the content you need to be familiar with. So if it's here, read through it. There's med cheat sheets here on cholesterol and hypertension. And these are, I just have to give a shout out to my husband. My husband is a pharmacist, and he helped me update this year, these sheets on all the lipid medications, all the hypertension medications. Now, you don't have to memorize all of those for this exam and know doses and, all the names of them. No, but what you need to know is, what about statins? How when do we utilize them for people with diabetes? When do we use moderate or high intensity? And what are the side effects? For the hypertension meds, you need to know that if people have renal disease, we start with the ACE or ARB. What are the side effects of ACE or ARBs for people with hypertension? And then being familiar with, the thiazide diuretics and the calcium channel blockers and the beta blockers. What are some overarching themes for those? And so you want to spend your study time wisely. I know it's limited. I know you have a whole life in addition to studying for this exam, but I try to consolidate information in these cheat sheets that are very helpful. I have a really great one, Screening and Diagnosis of Diabetes Mellitus, that is helpful. And of course, our pocket cards, really great for memorizing the medications. I do have a 220 test question let's see, toolkit, as we call it a toolkit, that you can utilize to practice taking test questions on a computer screen. And it's 220 in total, but we break it up into little chunks of 50 questions each. You could time yourself, see how long it takes, see how many you get correct. If you are achieving about 80% getting correct on these test questions, along with the ADCES review guide, it lets you know you're ready to take the exam. So 80% or higher. Of course, the test questions I write are not written. I'm not a professional test writer. I mean, I've taken courses on it, but the goal of the questions I ask is to make sure you know these key content areas, and also provide some challenge and just practice with getting to the best answer. The other thing I want to really recommend you do is go to our Facebook certification exam study group and join in, because it's a self-run group. We're over 1,000 people strong right now, that they support each other on the exam, study tips, different information that's helpful for exam preparation. So we're here to help you earn that CDCS after your name. We have a prep bundle, virtual conference. We have a bunch of free courses that can help you address content areas in the exam that you may not be that familiar with. So let's talk about some sample test questions. Questions, answers, and pitfalls. I've mentioned this already, but man, it's just worth repeating. You want to keep it person-centered. Start with the individual. Where are they at? Don't add anything into the question. So when you get that test question, you're going to read it through, and then you're going to think, what are the characteristics of this person? You're going to read all the answers, and then you're going to read the question one more time, just to make sure you know the intent. And then you're going to start where that person is at without adding in any additional details or adjusting it to make answers fit. You're going to keep the participant characteristics in mind. And remember, we are supporting efforts toward behavior change. That's our goal. To increase success, so you might read the question and you're like, oh man, I know this. I totally know the answer. And then you look at the answers, your answer is not there. So then you want to pivot. You're going to pivot. Just keep imagining this, and you're going to breathe and readjust. You might have some anxiety during this exam. That's completely expected. And anxiety is not a bad thing. Anxiety is energy. It's adrenaline. You want to harness that adrenaline. You want to, if you're feeling like too much adrenaline, put your hand on your heart. Take a few deep breaths. You can do that Wonder Person pose, put your arms up. That can really help decrease your adrenaline and get you more focused. And let your body know, okay, I'm in charge here. And you might want to think of, look for something orange in the place that you're sitting, just to calm your brain down. So anxiety or adrenaline is wonderful if we can harness it, but if it floods our brain, it can make the answers more difficult to see. So if you're feeling that, just take a few minutes to calm your heart rate down. Do whatever, like have a plan ahead of time, and make sure you're not dehydrated, because if you're dehydrated, your heart rate can go up a little bit too. So make sure you're fed, hydrated. I sound like your mother. I know, I apologize. I do have some mothering qualities in my personality. Yeah, so make sure you're well fed, hydrated, get a good night's sleep, and just put your hand on your heart. You got this. Okay, make sure the answer you choose fits the situation. And gosh, y'all, leave your clinic goals behind and focus on national goals. I mean, Your clinic or your whatever work setting you're working in may use national goals or they may not. So just know the national goals. That's really critical. How to work a test question. So they're going to have vignettes in there. And when I think of vignettes, I think about this wheat field where you're like, whoa, all this information. How do I get through this wheat field? You're going to take a deep breath and you're going to weed through the details and you're going to make sure you really understand the key intent of the question. Read the question, read the answers, read the question. And then you're going to say to yourself, okay, based on all of these options or answers, there has to be some that's wrong. So don't say to yourself, oh, is this right or wrong? Say true or false would be another way of doing it. So go, is this question true or false? It has to be true in all situations, based on the intent of the question. So get rid of wrong answers. And then it doesn't say select the right option. It says select the best option, because you might be left with two answers. You're like, oh man, these both could be right. But then you're going to say, listen to Beverly's voice, select the best one. One is going to be better than the other. That's the one you want to gravitate toward. So look for clues in the answers. If the answer has these words in it, it's probably not the best answer because we're dealing with human behavior. Answers with the following words are usually correct if they have seldom, most, generally, tend to, probably, usually. Why? Because we're dealing with humans. We need a little flexibility. If we start where the individual is at, not everybody is going to achieve an A1C of 7%. Like my mom is in her 80s and she has diabetes and she came back and she has an A1C of 7.5%. That's perfect. That's exactly where she needs to be for someone on insulin, given her age and her, situation. So we need that flexibility for people. We start where they're at and we give them some wiggle room. All right, what else do I have? Don't leave any answers blank. So on the exam, you'll have a chance to mark answers if you want to come back to them. And if you notice you're just reading a question over and over again and you're feeling stuck, just mark it, come back to it. Go to some other questions that are easier, build up your confidence again, and then go back to that one. Keep taking those deep breaths. Look for clues in the questions. Okay, juicy answers. What am I talking about? Well, those are answers that are familiar. It's like your most comfortable couch. You just want to lean into that, adjust the pillows, take a little nap, but they don't match the intent of the question. And the test writers are pretty good at throwing in juicy answers that they just sound good. You've heard them before. It's kind of something you've heard before, but it doesn't answer the question. So just be aware of those and look for the best answer. Your life experience is so important on this exam, but don't add in little details about into the question about your life experience. Just use what you have at hand. Okay, have a plan to address test anxiety, and you will be able to work out math problems on a blank piece of paper that is evaluated by the test administrators. Hey, look what we made it to the first question. So for this first question, I'm just going to read it out loud and read the answers, and you're going to choose what you think is the best answer. And this is a really safe opportunity for you to practice choosing the best answer. And if you don't choose the best answer, it's totally okay. If you choose the wrong answer, you still learn something. If you choose the best answer, you learn something. So it's a win-win proposition. And I don't see anybody's individual choices. So I'm really going to encourage everybody, listen to your gut, listen to that little voice inside of you. That little voice inside of you has a lot of wisdom, and trust it. And then we'll go back and see what happens. Okay. A patient is admitted to the hospital with elevated glucose level and a strong family history of diabetes. She is started on fluid replacement and is placed on a clear liquid diet. Her father is in the room and is very concerned. Which of the following would suggest a diagnosis of new onset type 1 versus type 2 diabetes? A, hyperglycemia, B, polyuria, C, ketosis, or polydipsia? So they're admitted to the hospital, elevated glucose, strong family history, started on fluids, placed on clear liquid. Her dad is in the room and is concerned. Which of the following would suggest type 1, new onset type 1 versus type 2? Take a few more seconds. So just use your spidey sense and make a choice. All right. Thank you, team. I'm going to close the poll and share your results. And I have to honestly say, this is the best result I've ever experienced on this test question. So 97% of you chose C, some of you chose A, but ketosis, is that the best answer? Absolutely. Great job, team. So let's just kind of dissect this question a little bit. There's a lot of information. This is kind of like weeding through the question. That's kind of interesting, but doesn't really help us with the actual intent of the question. So they come in, elevated glucose, strong family history, on fluids, clear liquid, her dad is concerned. But the main crux is how will we differentiate between type 1 versus type 2? So some folks chose hyperglycemia. Would a person with new type 1 have hyperglycemia? Yep. Would a person with type 2 have new type 2 have hyperglycemia? Yeah, that's the definition of diabetes, right? Fasting 126 or greater, or A1C of 6.5 or greater. So that doesn't differentiate. Would they both have frequency of urination? Yep. I mean, not all type 2s will have polyuria, but they could have it. And people living with new type 1 definitely experience polyuria. And then ketosis. So what is ketosis? Well, ketosis happens when the body burns fat for fuel. Why does the body burn fat? It doesn't have enough insulin. So ketosis is a differentiator because people with type 1 diabetes are insulin deprived. They don't have enough insulin to use glucose for fuel. They're using fat for fuel. People with type 2 diabetes still have some endogenous insulin production. So it is rare that they get ketotic. They're usually hyperglycemic without ketosis. So that's a differentiator, is ketosis. Great job, team. Let's go on. I always want to say one more thing. So if you don't choose the best answer, you just go to yourself, oh, okay, that's interesting. I'm going to fill in my knowledge gaps, and maybe I'll study more about the pathophysiology of type 1 versus type 2. This is when you take sample test questions. That's what you want to do. If you don't choose the best answer, just think, oh, I've got a knowledge gap. Let me study that area. So these questions are super helpful to identify where you want to put your effort. Okay, MJ has type 1 diabetes and wants to know the possible complications that can result from hyperglycemia during the first trimester of pregnancy. Which of the following complications can result from first trimester hyperglycemia? Is it A, macrosomia, B, vascular defects, C, shoulder dystocia, or D, spina bifida? MJ has type 1, wants to know complications that can result from hyperglycemia during the first trimester. Which of the following complications can result from first trimester hyperglycemia? All right. Thank you for taking a risk and choosing what you think is the best answer. I'm closing the poll and sharing your result. So 23, what's a lot of varied responses here? 23% A, 31% B, 11% C, 34% D. So what is the best answer? Let's look at the question again. So this person is type 1 and they're worried about pregnancy and hyperglycemia. And they're wondering what complications can result from first trimester hyperglycemia. And so you may not work with diabetes and pregnancy, and this might feel like a question that kind of throws you off. And I understand that. But what I want you all to do is remember you have a long and storied history of clinical knowledge, and just think back, like what happens during the first trimester? What is happening in utero? And it's the development of the organs, it's organogenesis. And so you're thinking, okay, if there's hyperglycemia during organogenesis, what can happen? And that what can result from that is anomalies of the organs that are developing. And so even though macrosomia is a juicy answer, because we usually think of macrosomia as being associated with gestational diabetes, because the babies are getting more glucose. The glucose is flowing from the mom to baby during pregnancy, but the insulin from the mom does not flow from mom to baby. The baby is going to make the fetus is going to make their own insulin. So insulin's a growth hormone, and it can make the fetus very large. That's macrosomia. So that's usually associated later in pregnancy and more associated with, gestational diabetes. So we're looking at type 1 first trimester, what problems can happen. Now, vascular defects is a juicy answer, but it's not the best answer. It's not specific enough. Shoulder dystocia, that's from a larger baby. As they're, birthed vaginally, they can get a dislocated shoulder because they're large and have a lot of fat padding. So the best answer is actually spina bifida, incomplete closure of the spinal column. And that makes sense because of the hyperglycemia during organogenesis can cause these congenital defects or anomalies. So D is the best answer. Now, if you chose something else, okay, just, gives you information that I need to study more about diabetes and pregnancy. And we do have in our online series a course on diabetes and pregnancy that I think you will find very helpful to fill in knowledge gaps. Also, you could seek other resources like the ADA standards of care. And then there's that big desk reference that has a whole chapter dedicated to diabetes and pregnancy. So you just want to think, how do I gain more information? What's comfortable for me? And then figure out how to fill in knowledge gaps. There are going to be questions on diabetes and pregnancy and pediatrics on this exam. So you want to be very familiar with those two areas. Okay, read the following vignette to answer the next 3 questions. We have a 47-year-old man with newly diagnosed type 2 and hypertension. What else do we know about him? Married with 2 teenagers. He's a professor with a BMI of 32. Started on metformin 500 milligrams twice a day. Father died of kidney failure secondary to diabetes. So it's a very common type of question where they'll give you a vignette and they'll say, the next 3 questions are based on this vignette. Okay, and every time they have the question on the screen, the vignette will reappear. I don't have that ability with these slides, but just I do summarize it for you in the following slides. So we have a 47-year-old type 2, hypertension, married, 2 teenagers, professor, metformin 500 twice a day, and dad died of kidney failure. So vignette style question number 1. He says finding time to exercise is challenging due to his work schedule. Using a trans-theoretical model, what stage of change is he in? A, contemplation, B, cost versus benefit, pre-contemplation, or D, denial. So finding time to exercise is challenging due to his work schedule. Using a trans-theoretical model, what stage of change is he in? All right, I see your answers coming in. I can see people changing answers. It looks like a horse race to me. I just see these bars. Okay, I'm closing the poll. Wow, 91% of you participated. Thank you. So 21% of you said contemplation, 15% said cost versus benefit, 5% said denial. Most of you chose pre-contemplation. So let's just take a look at this. So he says exercise is challenging due to his work schedule. And let's just think about contemplation. Do you feel like when you think about the word contemplation, and the trans-theoretical model is the readiness to do something model, and there's pre-contemplation, and there's contemplation, and there's, readiness and action, and so forth. So, anyways, contemplation means I'm thinking about it. Is he thinking about it? No. He says finding time to exercise is challenging. So he's not contemplating it. Contemplating it would be, oh, I'm trying to exercise, but I'm having trouble getting it, incorporating into my work schedule. That's contemplation. I'm trying to do it, right? He's thinking about it, but he's not even thinking about it. He just says, no, I can't really exercise. I'm too busy. So he is in pre-contemplation. He's not yet thinking about it. But we could move him from pre-contemplation to contemplation. We could say something like, oh, it seems like it's really challenging for you to find time to exercise at work. And he'll be like, yeah. And then you would say, well, have you ever exercised at work before? And he's like, actually, I used to walk with my friend during lunch. And you go, oh, is that something you could, enact again? And he might go, huh, I did talk to my friend the other day and he wanted to walk. So maybe I could start walking again. Okay, we got into contemplation. Do you see the difference? Okay, this is challenging. This model is a challenging model. So I have a whole webinar dedicated to explaining this model that you can listen in for free. Now, cost versus benefit is the health belief model. It's not part of trans theoretical, and denial is more like that Kubler-Ross, grieving theory. So these two belong to trans theoretical, and you have to figure out, are they thinking about it or are they not thinking about it yet? And this answer is pre-contemplation. I hope that was a helpful explanation. Oh, here it is. Behavior change theories made easy. And I'm going to be teaching that April 22nd, or you can watch it, and it's free. It's completely free, or you could watch a recorded version today after we end this conference. You could listen to it anytime, or even listen to the podcast. So that's definitely will be helpful. Okay, so Vignette, we're still on this professor. He requests information about healthy eating. Which meal planning approach best suits this individual until he can see a registered dietitian? A, very low calorie diet. B, eliminate all concentrated sweets. C, eat 3 meals a day with snacks in between. Or D, the plate method. All right, we'll take a few more seconds. I'm closing the poll and sharing your results. So 91%, this group is exceptional. I just have to say that. 91% of you said plate method, 3% said C, 6% said B. So what is evidence-based? We're always trying to think about starting with the person and then also considering which of these answers are based on evidence, and how would you know which ones are evidence-based? Well, you've got to read the ADA standards of care, and the ADA standards of care standard 5, they talk about medical nutrition therapy, and there's also other ADA articles that discuss medical nutrition therapy if you want more details. Also, we have our virtual conference coming up, and we have 4 hours on medical nutrition therapy. It's so great. Christine's going to be teaching that. So there's different ways to get this information. Let's just look at B. You're already suspicious of B because it has the word all. Eliminate all. We don't really do that in diabetes anymore. I will say in the old days, we would give people a sheet and say, don't eat these foods. We don't do that. We say, what do you like to eat? Let's adjust it to make it a little healthier. But we never would say, you cannot have this food. It doesn't work. We could say that all we want, but people make their own decisions, and we want to support them in getting to their best health. Okay, eat 3 meals a day with snacks in between. Yeah, we don't say that anymore. It's not really based on evidence. And I remember when we were promoting this meal planning approach, it's called grazing. People would say, I'm not hungry, but I'm making myself eat. And then they would, most of them were gaining weight. Not a great choice. But the plate method actually has some great data based on evidence and research that it's effective for people, it's accessible, it's easier to share this information in a way that's digestible, no pun intended, and it can really help people make some significant behavior changes. Okay, let's go on to a new person. This is going to be some math involved. JL uses an insulin pump and is carb counting using exchange list. A typical breakfast includes half a banana, 1 cup of milk, 2 tablespoons almond butter, and a piece of whole grain bread. LS's insulin to carb ratio for breakfast is 1 to 12. For lunch and dinner, it is 1 to 15. Based on this, how much insulin does LS need for breakfast? A, 3.5 units, B, 3.8, C, 3 units, D, 2.8 units. So they use an insulin pump and they're carb counting using exchange list. What's their breakfast? Half a banana, a cup of milk, 2 tablespoons almond butter, and a piece of whole grain bread. Their insulin to carb ratio for breakfast is 1 to 12, for dinner is 1 to 15. How much insulin does LS need for breakfast? All right. I'm going to launch the poll. And as I haven't mentioned this, but they will have the calculator embedded in the screen if you're doing a remote exam. And if you're doing it in a testing site, you will be allowed a paper and a writing tool. And also they usually provide a calculator. All right, thank you. I'm going to close the poll, share your results. So 47% of you said A, 29 said B, 9% C, 15% D. All right, so let's just take a look at this. And I need to tell you something important. And the first thing we need to pay attention to, he's on a pump. So anybody on a pump can do tenths units, right? We don't have to round up or round down. They can get very precise on their insulin dose. And they're using an exchange list. Now, the exchange list is still alive on the exam. Just based on some feedback I've received. So in the exchange list, I just want to tell you, milk is counted as 12 grams of carbohydrate. If we're doing a carb counting list, milk is generally 15 grams. But if they specifically say exchange list, just burn this into your brain. Milk is 12 grams of carbohydrate. So that's one thing you need to know. And the other thing you need to make sure you're doing is dividing by the right denominator. So this is breakfast, and the carb to insulin ratio is 1 to 12. I think some of you divided by this denominator for lunch and dinner, which is the insulin to carb ratio of 1 to 15. So just make sure you have all of that clear. So let's add this up together. Half a banana is 15 grams, a cup of milk, 12 grams, almond butter is a fat. We don't count any carb in that using the exchange list. It's just a fat protein. A piece of whole grain bread is 15. So what do we get to here? We got 15 plus 12 plus 15. That's 42 grams of carbohydrate. And our denominator, since this is breakfast, we divide by 12. 42 divided by 12 is 3.5. So if you chose 3.5, you got the best answer. If you chose 3.8, you probably counted milk is 15 grams. If you chose 3.0 or 2.8, you might have used the wrong denominator. So this is just a very typical example of the type of questions that are going to appear on the exam for insulin and carb counting. You want to be comfortable and familiar with these. And on our online courses, we do have examples of this so you can get a lot of practice. And Diana Isaacs during our virtual conference does a lot of these also. So super helpful. Okay, let's keep going. So this is, I put some of these questions in here that are more, there's a lot of details because I want you to get comfortable weeding through the details. So KL is 72 years old with a 10-year history of type 2 diabetes. KL has a BMI of 24.6, A1C is 7.3, LDL cholesterol is 72, GFR is 62, and urinary albumin creatinine ratio is less than 30. Has a history of hypertension. Current meds for diabetes include metformin extended release, 850 twice a day, sitagliptin, which is Januvia, and that's what they'll do on the exam. They'll have the medication, generic, and then the trade in parentheses, 25 milligrams. Based on the ADA standards of care, what is the next best action? Add an SGLT2 inhibitor to lower A1C and preserve renal function. B, determine KL's A1C goals and explore social determinants of health. C, stop sitagliptin and suggest initiation of a GLP-1 receptor agonist to reduce cardiovascular disease. Or D, refer KL to a RD/RDN to help get A1C less than 7%. KL is 72, 10-year history of type 2. Their BMI is 24.6, A1C 7.3, LDL is 72, and GFR is 62, with the UACR less than 30. History of hypertension. Current meds include metformin and sitagliptin. Based on the ADA standards of care, what is the best action? Okay, I'm going to launch this and see what you all say. All right, thank you for participating. I'm going to close the poll and share your results. So we had 36% of you said A. We had a tie. 36% said B, 22% said C, 6% said D. Okay, this is such a great question. And let's just take a look at it together. So they're 72 years old with a 10-year history of type 2. For somebody who's 72, how is their BMI? Yeah, we consider a BMI of 25 or greater overweight, so that their body weight looks, is just within the desired range. How's their A1C? A 72-year-old. Yeah, I'm thinking that A1C seems to be pretty on track. Let's take a look at their LDL. We know that for people with diabetes, we want the LDL cholesterol less than 70, and if they have heart disease, less than 55. How is our GFR? The GFR, we want that more than 60. His is more than 60. This is kidney function, and we want the UACR less than 30. So there's no extra protein in his urine. His kidneys are great. He has a history of hypertension. So his current meds for diabetes include metformin. Is that a good choice for him? Yep. Is sitagliptin a great choice for him? Yep. It's going to decrease his A1C by about 0.5. But what is the next best action? So 36% of you said, hey, let's get him on an SGLT2 to lower A1C and preserve renal function. Well, his renal function is okay. And his A1C might be okay, depending on what the person says. So this is not going to be an automatic action that we take. We're going to have to do something else. Some people said stop the sitagliptin and get him on a GLP-1 to reduce risk of cardiovascular disease. Well, look at his BMI and his age. Is that what we really want to do? Do we want to maybe decrease his appetite and impact his weight? If that's something he wants to have happen. And then some people said, well, let's refer him to the RD to get that A1C less than 7, but is that his goal or this person's goal? So that's why B is the best answer. So when you see an answer that says explore social determinants of health, determine KL's A1C goals, go toward that answer, because this person has pretty great health considering their age and other factors. Yeah, sure, we want to address the hypertension, but they may want to continue on this course Or they might want to say, you know, my dad had kidney issues. I want to get on an SGLT2. Or they might say, oh, gosh, I just feel like I have extra weight. I like to get my blood glucose down and lose a little bit of weight. We're going to have to listen to what their goals are. So that's why B is the best answer. If this person's kidney function was diminishing and they were in stage 3 renal failure, you know, I would lean more towards starting an SGLT2, but we have to do some more exploration before we take action. We always start with the person's values, needs, and preferences. That's why B is the best answer. Okay, great job, team. Oh, this is another free webinar I offer talking about language that respects the individual and imparts hope. And you could see that this is recorded and ready to go. I'm going to be re-recording it sometime this year. Let's do another question. You're doing so great. Metformin is an anti-diabetic agent different than that of sulfonylurea drugs. Some features of the drug are that it, A, stimulates insulin secretion and increases hepatic glucose production. B, causes hypoglycemia. C, lowers hyperglycemia in people with diabetes, but does not lower blood glucose in people without diabetes. D, results in weight loss and can cause kidney damage. So metformin is different than other medications. Some features of it are which of the following is correct? Stimulates insulin secretion, increases hepatic glucose production, causes lowers hyperglycemia, or D, results in weight loss and can cause kidney damage. Thank you for choosing an answer. I'm closing the poll. Okay, sharing your results. 36% of you said A, 55% said C, and 9% said D. This is a great example question of getting rid of false answers. So let's start with the first one that 36% of you chose. Now, you're going to be familiar with what metformin does because you're going to be super knowledgeable about what's on these pocket cards. So that's not going to be an issue for you on the exam. But what if you didn't really know what metformin does? Well, you're going to use your common sense. So always pull upon your common sense. And sometimes you might read a question and it can invoke anxiety. Take that deep breath and say, I've got common sense. I'm going to tackle it. So even if you know nothing about metformin, could it stimulate insulin secretion? Okay. hmm But would any diabetes drug increase hepatic glucose production? What does that mean in English? It means tells the liver to make sugar. Now, no diabetes medication would tell the liver to make sugar. It would tell the liver to stop making so much sugar. But I think what happens is people read the first part of this and you're like, yeah, lowers blood sugar. And then the second part, you're like, I, I don't know what happens exactly, but maybe you read the word decrease instead of increase hepatic glucose production. Sometimes we want to make an answer fit. So this is I'm so glad you had the opportunity to do this today, because then you go, oh yeah, I need to make sure I read increase or decrease, you know, above or below, up or down. Those qualifying words are so important to read carefully. So A is not the best answer. What class of medication actually does stimulate insulin secretion? I'm looking for my pancreas. It's over there. It's actually the sulfonylureas and the meglitinides. They're called secretagogues. They tell the pancreas to make insulin. Metformin actually tells the liver to stop breaking down so much glycogen. It's very important in that way. Okay, so A is not the best answer. So you could, even if you don't know anything, you're like, oh, no, it doesn't increase hepatic glucose production. Nobody chose B. Metformin does not cause hypo. The only meds that cause hypo are insulin, sulfonylureas, and meglitinides. D, it's called weight neutral, just so you all know. It doesn't cause weight loss or weight gain. Some people might lose weight if they're getting some GI side effects. And it does not cause kidney damage. There's a lot of mythology out there in social media that metformin can harm your kidneys. It does not. And we need to reassure people with that. I was just doing a study the other day for CGMs, and a person was saying that, yeah, they're afraid about taking the metformin. They've heard really bad things about it. And metformin is the most widely used medication for diabetes in the world. It's cheap, it's effective, it doesn't harm your kidneys or any other body parts. So we just need to make sure the person has adequate renal function so the metabolites don't build up and cause lactic acidosis. Okay, sorry, that was a long-winded answer, because I hear it so much from the people that I serve, and you're hearing it too. It doesn't harm the kidneys. It protects the kidneys because it lowers blood glucose. So C is the best answer. And C is kind of a weird answer, but all the other three are incorrect. C is the best answer. It lowers hyperglycemia, but if you don't have diabetes, it's not going to bring down your blood sugars. Okay, medication pocket cards and our website. Oh, and the CDC Coach app. You can download this. The great thing about the CDCES Coach app is that I also have a question of the week I publish, and then a rationale of the week that gives a detailed explanation why a particular answer was the best answer to help you get ready for testing. Okay, I think this is our last question. A person with type 2 is on twice daily dose of basal bolus insulin and complains of waking up with morning headaches. If the fasting capillary blood glucose is 291, advise the person to do what? A, increase evening dose of basal, B, increase morning dose of bolus, C, check 3 a.m. blood glucose, or D, eliminate bedtime snack. So person with type 2, twice daily dose of basal bolus on insulin and complains of waking up with morning headaches. Fasting capillary is 291. What are we going to do? We're going to increase evening dose of basal, increase morning dose of bolus, check 3 a.m. glucose, or eliminate the bedtime snack. All right, I'm closing the poll. I just love your participation. So let me show you results. 56% of you, or 59, said A, 32% said C, and then there was a smattering of other answers. So let's just break this down. So a person has type 2, they're on twice daily dose of basal bolus insulin. What does that mean? Well, it means they're on the long-acting and a short-acting insulin. And that's sometimes called split mix on the exam. If you hear split mix insulin, it's basal bolus. And sometimes it's those pre-mixed, like the 70-30 or the 50-50. Okay. Anyways, so we know they're on fast acting and short acting, and they complain of waking up with morning headaches. Is that significant? Yes. We cannot skip the morning headaches. What does morning headaches signify? It signifies hypoglycemia. People who wake up with morning headaches on insulin, we want to see what was their blood sugar doing overnight. Did they get low? We're going to ask if they've had vivid dreams. Do they wake up sweaty? Do they wake up and get food? This is such an important sign to recognize and to take action around. Now, why would they get morning headaches? Well, that insulin they're taking twice daily, so maybe they're taking it before dinner. It's just too much insulin before dinner, so their blood glucose levels are going low overnight, known as nocturnal hypoglycemia. Now, when you have nocturnal hypoglycemia, what happens? Your counterregulatory hormones kick into gear, and then you release, adrenaline and cortisol and the other corticosteroids to try and raise your blood sugar back up. So why is it 291? Well, this person is having rebound hyperglycemia. Nocturnal hypo with rebound hyperglycemia. And so based on all that information now, would we increase the evening dose of basal insulin? Because that would even make that blood sugar go down lower and potentiate a dangerous situation. Would we increase a morning dose of bolus insulin? Well, We might, but that's not really getting to the crux of the matter. Would we check the 3 a.m. blood glucose? Yeah, I want this person on a CGM. I want to see what's happening overnight. I'm assuming they're getting low blood glucose, but I want to verify. If there's not the answer that I want here, which would be decrease the evening dose of insulin. That's the answer I want. It's not here. So I have to choose the next best answer, which is check 3 a.m. blood glucose. Am I going to eliminate bedtime snack? No way, because then their blood glucose will go down even more. So the best answer is check 3 a.m. blood glucose. 32% of you chose that. Now, if you didn't choose it, I totally get why. I mean, I think it's sometimes you just are not familiar with this morning headaches as being a sign of nocturnal low blood glucose. And so how do you fill in those knowledge gaps? Again, taking courses on insulin pattern management can be really helpful. Reading chapters or the standards of care. I'm not sure how much they talk about this, but standards of care does talk about pharmacologic management. I would say our courses are super helpful in that regard. And then just to give yourself more opportunity for test taking, I've talked about our test taking toolkit. And here I passed my CDE exam. I think that was the 5th time I passed it, and I just did a funny picture. But we are here to help you earn the CDCS after your name, and we have ideas on how to do that. And so I just want to briefly kind of summarize the services and online courses we offer to help you fill in knowledge gaps. And we've been doing this for a long time. We're in our 26th year now, and we've been really fine-tuning our approach to these courses in our online university and helping people find that path to success. And our level 1 courses are really the fundamentals, and they just talk about the pathophysiology, meds, insulin. They're not basic at all. They just will provide you with the foundation of diabetes knowledge to go to the next series of courses, which is standard 2. Level 2 are standards, and our standards courses are so important because I break down the ADA standards of care. The ADA standards of care is 300 pages of very condensed information, and it's hard if you're just looking at it for the first time or trying to study to figure out what's most important. I have read the standards of care every year for 30 years, and I know what changes are being made, and so I just have this mental history. I have a legacy history of the standards. And so I'm able to kind of summarize for you and pull out most important points to know for the exam. And I say for the exam, and it's really for your clinical practice too. Level 3 is our diabetes mastery and certification readiness. And that means, okay, you're ready to take the exam. Level 3 will help you get into the mindset, because we not only give you a ton of poll questions like what we did today, like every class, I'll give at least 8 poll questions. There's also at least 8 questions as part of getting your CE for that particular course. I just want to pummel you with questions, because the more test questions you take, the more comfortable you get with it. Now, level 4 is not designed for the CDCS exam, but you can certainly utilize some of these courses to fill in knowledge gaps. I have a great course on insulin calculation that will really help you figure out how to determine how much insulin people need. Solving glucose mysteries for type 1 and 2 also dives into pattern management, as does basal bolus therapy. And then I have other content that is not exactly tied to the ADA standards, but very instructional. We're trying to build bridges and bring more people into the diabetes education community. We're offering a lot of scholarships. This year alone, we've offered 17 scholarships so far to attend our virtual conference, and that's our commitment to the future generation of diabetes educators. And we're teaching April 16th through 18th. That our team is teaching the virtual conference, which really highlights the standards of care, technology, pattern management, insulin therapy, and then we talk about medical nutrition therapy. And the great news is I'm very aware of budgets, and I want your dollars to go as far as possible. So we bundle these courses, and we have a CDCS bootcamp bundle, which includes level 1, 2, 3. We have a dual certification bootcamp, which includes like most of our courses, or we have a BC-ADM and our virtual training conference. We try to make these as reasonably priced as possible so that you can really gain the most from this content. The thing about succeeding at this exam is knowledge equals confidence. As you identify your areas or you have knowledge gaps, and you fill in those knowledge gaps with information, it's like taking a deep breath. And that deep breath is going to help you move toward exam readiness. We have a success page. I hope you can check it out. It's on our website, diabetesed.net. And it just, all of the graduate success stories, they're people just like you, who had this dream of achieving their certification and made it happen. And we were part of that journey, and we're so happy to be a part of yours. So here's our certification exam study group. You can click on there, ask questions. There's tons of resources there. And we also have a lot of posting on different social media sites with the latest information. And I just want to thank you so much for joining us today. I feel like you're going to do great. Anybody who comes to these free webinars, whether you're coming live or listening to the recorded version, you're a super achiever. You want to make this happen. You want to get all the information and tools necessary to succeed. So I believe in your success, and I want to support you on your journey, as does our whole team. Here's our contact information. So on that note, I want to thank you and appreciate your time, and stay after class to answer any questions. This is Beverly Thomassian signing off. Thank you.